Bismillahirrahmanirrahim. Our today's discussion is about nutrition. Nutritional status, it is an important determinant of outcome after surgical treatment. Pre-operative nutritional support, it significantly reduces the perioperative morbidity and mortality in patients with severe malnutrition. For example, in case of CA esophagus, when there is the patient is nutritionally deficient for weeks, months, this nutritional deficiency, it is very important if you are to operate. And so in these nutritionally deficient patient, pre-operative assessment of nutritionally deficient elements, it is very important, and then you are to cover this deficiency. Now, how will you nutritionally assess? How you do this nutritional assessment? There are different ways. First, it is the history. You interview the patient about the change in dietary habits, and if there is a history of a recent weight loss, it is very significant. The 5% weight loss in last month or 10% over the 6 month, it is very significant. And then the other way, it is the body mass index. What is body mass index? It is the weight in kg over height into meter square. The normal value, it is 18.5 to 24.9. If the weight, it is less than 18.5, there is a nutritional impairment, and less than 15, it is severe malnourishment. And if the body mass index, it is 25 to 29.9, this is overweight patient. So what is the underlying disease? It is very important. And the other symptoms: anorexia, nausea, vomiting, dysphagia, GERD, and generalized muscle weakness. After history, the other way to assess the nutritional deficiency, it is the physical examination. The skin of these patients, it is flabby or loose. There is a peripheral edema, and this indicates hyperproteinemia. Muscle weakness, especially the thenar and temporal muscles, they are weakened. The bulk, it is reduced. And the more subtle changes: skin rashes, pallor, glossitis, hair changes, hepatomegaly, neuropathy, and dementia. These are the other features which are indicating the poor intake and a nutritional deficiency. The third is anthropometric measurements. The triceps skin fold thickness, it is reflecting the body fat stores. Then the mid-arm muscle circumference, it is showing the skeletal muscle mass. Obviously, this is reduced if there is a nutritional deficiency. In laboratory tests, there are a few tests which are important. First, the serum albumin. If it is less than 3 gram per deciliter in a stable hydrated patient, it is significant. Serum perialbumin, it is a more useful indicator of acute changes. And then the serum transferrin less than 200 milligram per deciliter, it is significant. And then the assessment of the immune function, delayed type hypersensitivity, if there is allergy to common skin antigens, the total lymphocyte count, if it is 1500 to 1800, it is a mild depletion. If it is 900 to 1500, it is a moderate depletion, and less than 900, it equals severe depletion. It is showing severe depletion. So these are the different ways of assessing nutrition. Now, what is the calorie requirements? The normal requirement, it is 20 to 30 kilocalorie per kg per day, and this is ranging from 1300 to 1800 kilocalorie per day. In most stress patients, the requirement it is increased, so it is now 25 to 35 kilocalorie per kg per day. The nutrients required, these are the glucose, fats, proteins, amino acids, vitamins B and C, minerals, sodium, potassium, phosphate, and the trace elements, magnesium, zinc, iron. These are the nutrients which are required, which are important and essential. Now, what are the indications of nutritional support? There is a long list of these indications. If the patient is in prolonged hypermetabolic state, this is one indication. Even the preoperatively well-nourished patient who enter prolonged hypermetabolic period may require nutritional support. For example, if you are operating and there is a fistula formation and there is no nutritionally deficient patient, is you are to keep NPO for a long time. The patient becomes nutritionally weak and the patient is a hypermetabolic state. This is indication for this nutritional support. Without this nutritional support, there is impaired immune function, there is a poor wound healing, and there is a depletion of visceral protein stores. So these are the problems if you are not supporting this patient nutritionally. The other indication, it is the short bowel syndrome. Essentially, if you are operating and there is a gangrenous bowel after mesenteric thrombosis, superior mesenteric artery thrombosis, there is a gangrene bowel, small bowel, which is resected, resulting in short gut syndrome. This is one indication for this nutritional TPN. And proximal fistulas, this is other indication, and a high alimentary tract obstruction in cases of achalasia, strictures of the esophagus, neoplasia of the esophagus, gastric carcinoma, and pyloric obstruction. These are the other indications. And then if the patient is in prolonged paralytic ileus after major operations, multiple injuries, blunt or abdominal trauma, malabsorption, the patient who cannot ingest food, who regurgitate and can aspirate secondary to oral or tube feeding. Excessive metabolic requirements secondary to severe trauma, such as full thickness burns, major fractures, soft tissue injuries, and then the patients with enteritis, colitis, and carcinoma patients, these are the other indications for this nutritional support. Now, what are the roots of nutrition? One is enteral nutrition, that is for long-term basis by mouth, by gastrostomy tube, by jejunostomy tube, and then for short-term it is the nasogastric feeding. And the other way it is the parenteral nutrition. On long-term basis, it is the TPN, total parenteral nutrition, which is given centrally on central lines, and for short-term, it is the peripheral parenteral nutrition, which is given by peripheral lines. Now, the approach to nutritional support. First, the patient is nutritionally assessed, and then it is supported nutritionally for maintenance or for repletion purposes. And if the GIT it is functional, you give enteral nutrition, and if the GIT it is not available, it is not functional, you are to keep the patient NPO. Then the parenteral nutrition it is indicated. So this is a diagram to show these different routes. On the right side, you see the enteral nutrition, nasogastric, via nasogastric tube, the whole food it is given by mouth, and then the gastrostomy tube, then through the jejunostomy tubes, and through NG tube you insert the tube into the duodenum or into the jejunum. And on the left side there is a parenteral nutrition, total parenteral nutrition, that is through the central line, and then the PPN, peripheral parenteral nutrition, through the peripheral lines. So this is intravenous alimentation, hyperalimentation. These are the different preparations. You see this polycose and others, ensure, extra. So these are given through enteral route. Then what are the indications for enteral nutrition? Poor nutrient retention, prolonged NPO status, insufficient intake. These are the indications for enteral nutrition. This is the diagram to show this enteral nutrition. Nutrition by mouth. First choice of enteral nutrition. The nutrition by mouth, it is the first choice of enteral nutrition. Adequate, palatable, and varied diet is used. Cleanliness, it must be observed at every step, and assistance should be given to patient to take the food orally. Tube feeding. The patient is unable to take orally but have functional GIT. So you feed the patient through a tube. It maintains intestinal structure and function. It improves immunity. It avoids gastro-related problems, and it is cost effective, cheaper. Tubes are passed through nose and named according to the location of the terminal end: nasogastric, nasoduodenal, nasojejunal. And this is a short term use. For short term use, enterostomy tube feeding. They can be a temporary or permanent basis. Usually perform when the feeding it is required more than 4 weeks, and the passage of nasogastric tube it is not possible. And this enterostomy tube it is through gastrostomy or jejunostomy. Surgical gastrostomy. What are the indications for this surgical gastrostomy? Esophageal atresia, stricture and cancers, dysphagia due to neuromuscular disorder, post-traumatic. And what are the contraindications? Primary disease of the stomach. This is a contraindication for this gastrostomy. And abnormal gastric duodenal emptying. There is a gastric outlet obstruction. This is another contraindication for this surgical gastrostomy. And if there is a significant esophageal reflux, it is another contraindication. Now, what are the complications? Local irritation, skin excoriation due to leakage of gastric contents, hemorrhage, intraperitoneal leakage of gastric contents, wound hissins. These are the complications of this feeding through gastrostomy. This is a diagram to show balloon gastrostomy. Benefits of enteral nutrition over TPN. If the gut works, enteral nutrition is preferred. It is physiological. The nutrients they are metabolized and utilized more effectively. And immunological, the gut integrity it is maintained by enteral nutrients. This is another very important aspect. Safety. It avoids complications related to intravenous access, catheter sepsis, pneumothorax, arterial laceration, catheter embolism, and it is cost effective. It is cheaper. The cost of enteral nutrition formula it is less than parenteral nutrition, and also the cost of equipment and personnel. Contraindications to enteral nutrition. Expected need less than 5 to 10 days. These are the contraindications. Severe acute pancreatitis, high output proximal fistulas, intractable vomiting or diarrhea, peritonitis or IDS. These are the contraindications to enteral nutrition. Metabolic monitoring and clinical observation. These are the different investigations which are important while you are monitoring these patients. Serum electrolytes, blood glucose, blood urea nitrogen and serum creatinine, serum calcium, phosphorus, magnesium, liver enzymes, vital signs, body weight, 24-hour total urinary urea nitrogen, estimated nutrient intake, fluid intake and output chart. These are the important things which are regularly observed during monitoring. So, in summary, the optimal enteral nutrition, you select appropriate route, method of administration and formula, identify the problems, address and resolve the problem, avoid complications. This will optimize clinical response and outcome. Parenteral feeding. Parenteral nutrition is defined as intravenous provision of all nutritional requirements without the use of GIT. Parenteral nutrition is defined as intravenous provision of all nutritional requirements without the use of GIT. This is the definition of parenteral nutrition. Now, what are the indications of this parenteral nutrition? Massive intestinal resection, especially if there is less than 100 centimeter of small bowel. There is a short gut syndrome. There are so many causes of this short gut syndrome. When a larger part of the small bowel it is resected, for example in trauma cases and multiple tumors, and if there is a mesenteric ischemia and the bowel is gangrenous, and in cases of midgut volvulus, when most of the bowel it is resected and the patient is now in short gut syndrome, the bowel it is less than 100 centimeter. These are the indications for this TPN. Proximal intestinal fistula, inflammatory bowel disease, ileus, severe pancreatitis. These are the other indications for this TPN. Routes of delivery: peripheral parenteral nutrition, and which is given through peripheral lines, and then the total parenteral nutrition that is given through central lines. Now, what are the complications? There is a catheter sepsis, pneumothorax, arterial laceration, catheter embolism. The cost of enteral nutrition formula is less than TPN. Thank you.